little gal here, she has kind of some microtia going on, so perhaps she doesn't have an ear canal that's developed, so we can't put a traditional hearing aid because the sound won't be able to travel to the eardrum. So, and I'll show you a little bit more about the Baha, which is a device that presents sound through vibration. For folks that have a pretty significant hearing loss, we also have cochlear implants, and I'll talk a little bit about that as well.
So I have a question about
sure.
the little girl without the ear.
Yeah.
Is that surgically?
Yes.
Do they reconnect things and open things up?
So I have a slide about it, but I can, so do you mind if I go to that and then I'll show you?
Yeah.
If you still have questions, I'll answer it. Okay, perfect. All right. So just a quick little brief history. So hearing aids used to be these ear trumpets because it was recreating what the pinna does. It captures the sound, it funnels it down, it's amplified because it's this big opening. So that was what folks used. Then they decided, why not make this an accessory, something lovely for the home? And so they made these centerpieces, and so 4 people at the table, it's picking up the sound, and then it's traveling down the tube, and the person would just hold it to their ear, and they'd have access to the conversation at the table.
Wow. Interesting.
So it's like, okay, and you know, these, and I mean, if you look online, some of them are just like very exquisite. They're metal work, and they're beautiful. And I'm like, I would love to find one of those and just have it on a shelf somewhere in my hearing aid collection. So, yeah, but they're pretty neat.
That's cool.
Okay, so moving forward, you see this little kiddo, he has a body-worn hearing aid. Has anyone ever seen one of those?
Yes. Yeah.
Okay, yes, so it was a little device that had the microphones, and then it was strapped on the kids. A lot of men would just wear a pocket with a shirt, and then women, they actually had like undergarments that you could put your hearing device into, a little strap, and then it had 2 little wires that came up, and the sound was presented to the ears. So that was pretty high tech. Then we got analog ear level hearing aids. Oh my gosh, nothing with a cord, it's amazing. It's on the ear. We're able to make some adjustments as far as the treble and bass, if you kind of think of it that way, like a radio. And then from there, we've become the digital era. So hearing aids, I mean, so small, moving up into more powerful hearing aids for folks based on hearing loss needs and things like that. We choose the appropriate hearing aid. Something that's a little fun, there are some pretty interesting hearing aids. So this one is the lyric I was talking about, so that's the one I inserted into the ear. This is what typically a hearing aid looks like. You can barely see it. It's just this little wire that comes down. This guy has a gauge, so a piece of jewelry that is actually a hearing aid. So this tube going here is basically this tube going here into the ear, so it's kind of cool. We have hearing aids that are controlled by your iPhone. So they're wireless, so people will download the app, they need to turn their hearing aids up, they can geotag locations. So you drive up to your normal Starbucks, goes into your Starbucks program, you get your drink, and you're on your way. As you start to drive, the hearing aids kick into driving mode. When you get to work, it goes into your work program, and it's all by map, satellite, iPhone. Yeah.
I remember what I...
Oh, okay.
So, when doing an audio exam, occasionally we have patients that break their hearings. And, you know, we have a sound booth, and, you know, they always complain about hearing their heart and their breathing and all that stuff. But we actually have them respond, and I think the term they use, used as echo effect, where they have bad hearing in this one ear, and the decibel level goes up high enough, and I think what happens is they're picking it up on the opposite side.
Yes, it's called crossover or cross hearing.
Yeah.
Yes, yes. So our skull is only so wide, and so when you present a sound, for example, if someone has normal hearing, and once you start to approach, our default is at 40 decibels. When we see a difference between 2 ears, you present masking noise to the better ear to keep it busy in processing sound so you can fully evaluate that other ear. Because sometimes you get crossover, and so that hearing looks better because the other ear is actually helping out.
Does the machine know automatically to do that?
I don't work with I don't work with those machines. I'm not sure. Yeah. So,
We just have that little simple box machine, you know, the basic thing that we test.
yeah, no,
I don't think it's that
audiometer
smart.
that's all. I don't know, I don't think it's that smart, I know. I would probably say no. I would probably say no. So what would happen is your readout, instead of having the circle or the X, it would be a triangle or a square if it was masked.
So, but 40 decibels is the point, right?
Yeah, yeah. And then I do masking noise starting at 50 dB, and I do steps and threshold search going up to 70. So,
All right,
sorry,
thank
that's
you.
detailed
Yeah,
risk.
that's okay.
That's
Audio
awesome for me.
testers. Yes. Okay, so that's that. All right, so here we go, Baja. Okay, so getting to work at an ENT office, we see a lot of Baja patients, we call them. And they're, Baja is actually it's an acronym for one of the companies, so they call it more of an osseo-integrated hearing aid of sort, something, or it's got this other name that's not linked to a brand or manufacturer. But essentially what happens is, this illustration kind of shows a little bit better. An incision is made, and then a titanium screw is actually drilled into the bone, the mastoid, and from there, then the skin heals around it, and then when it is all healed, they come into the hearing health clinic where I program up the device. So I kind of do the technology component after that. And so what that does is basically bypasses your outer ear and the middle ear and directly stimulates to the cochlea. And that's the fluid filled, so it's through vibration. Okay.
So that's when the steps along the way are not working, so you have to short circuit and go the deeper route.
Exactly.
Okay.
We're bypassing the outer ear and the middle
Okay.
ear and going right to the inner ear. Thank you, Katie. Yes, that's quite a lot better. So yes,
Does that device actually kind of almost clip on that little screw?
it does.
You know,
Yeah,
like a click,
it's a button. Yeah, it's like a little button.
Okay.
Mhm. So when I show patients how to use it, I have a little disc that has the screw. And so I tell them, okay, your first go round, you're gonna rock it, and I show them how to put it on, because it's a pretty tight fitting, secure device. And then I tell them, okay, now you need to do it with your eyes closed. You need to find it and you need to put it on because you can't see what you're doing back here.
Yeah.
So we do a lot of practice, and that can be one of the most challenging things is just
Yeah.
getting the device on. So, yeah.
So if you implant that, do you have to bypass the normal channels for hearing?
So what this typically means is, so acoustically, so the outer ear and the middle ear, let's say there's no ear canal, so we cannot present sound down that ear canal, then we would use the Baja. If someone was born without middle ear bones, so that can't do that mechanical portion, that middle step, we would use a Baja, because we're bypassing that region, because something along that mechanical pathway is not working, so we go right to the inner ear.
So this may be done because of a birth defect or trauma?
Yeah, absolutely. Cholesteatoma, any of those slides we saw on the middle ear, things like that where folks have had chronic ear infection, mastoiditis, things like that, where that conductive component has affected the ossicles or that pathway. And sometimes, yes, folks will just be born without a pinna or anything like that, and they have hearing loss, so we have to put that somehow, get sound somehow. So this kind of takes out the hearing functions.
So this is kind of like a hearing aid though, in that it would only be worn during the day, then you take it out to sleep, to shower, to do all
Exactly.
those things. Okay.
Exactly, yes. So it's technically a hearing aid, but it's just, instead of presenting sound acoustically,
Yeah.
it's through the vibration and behind the ear. Yes, so a daily wear device that you would take off. Okay, cochlear implants. So these are for folks, there's a pretty strict criteria for candidacy, so it's based on degree of hearing loss, speech testing with hearing aids, so evaluating their benefit with the best fit hearing aids that you can have for that individual, and then and they also are getting a limited benefit from hearing aids. So when we see a really significant amount of hearing loss or folks who are born with no hearing, this is an option. A lot of times my patients, sometimes they do have some hearing, they use hearing aids, but they're struggling so much, they're to the point where they're like, I have nothing to lose because I can't hear with this hearing aid, I'm struggling, and so we'll go the cochlear implant route if they meet criteria. We just started cochlear implants at our office, Bellingham ENT, so we're really excited. We've had a couple of folks come through. We have an initial stimulation coming up. And sound, so we've talked about acoustic, vibration. Sound is presented through electrical stimulus, so it's an electrode. So there's two components. With the surgery, essentially they kind of make an incision, drill out a little bit of the bone and place this inner portion, and it has a ground because we're dealing with electricity, so we need to make sure to be careful of that. And then it has the electrode that travels through the bony portion, they drill that out, down through the middle ear space, and then it is slowly released into the cochlea. And it's on this little stylet, so it essentially curls around very slowly. And we just had one of our reps up, and she said that the most successful insertion of the electrode is when it takes like 3 to 5 minutes. So, and we're talking about something the size of like less than a dime, and they're just like very slowly pulling this thing out. So it's a pretty intricate surgery. And then everyone has a different outcome. So some folks who are really very active in learning how to hear with their cochlear implant, and they want to do well, they have familial or friend support, they do great. And you know, it's really exciting to see someone really benefit from an implant. If you're an adult and you are implanted after you've had a hearing aid for years, it really does take a lot of work. It's not like a hearing aid, put it on and go out. It's relearning how to hear with that because everything sounds different. So you have to figure out what you're hearing and put a label to a sound. So it's been very interesting. And there's another slide that I have that talks about kind of the rehabilitation, so I'll go with that. Well, this just talks about programming a hearing aid, sounds kind of boring. Okay, so, which it's not boring, it's my favorite thing to do, but maybe for you it might be boring.
How does it ground that? Is it like a little metal plate?
It's a little portion that it's a little electrode. So that little array has little electrodes on it where it stimulates the cochlea across the pitch range, because think of the cochlea, if you spread out that snail, it's like the keys of a piano. So low bass tone, mid up to high treble. So as it's all curled up, the electrodes are stimulating along the cochlea, and so that other little tail that went up to the side has an electrode that grounds the
But where does it ground on? Because electricity
The
goes round and
electrical
round and round and
circuitry of
round
the
unless you
brain,
stop
I
it.
would
It has to
imagine.
have a break, like light switch has a break.
That is a good question.
Yeah, it must have to do with something, because our bodies run on electrical circuitry.
Yes.
I mean, you've got your heart, you've got your brain,
Right.
you know, so I mean, there's definitely things in there.
Mhm.
You just have to be in the right, you know, like my mom and dad have pacemakers, and so it's like, yes, it's in the right area
Yeah.
to be grounded for that particular organ, so I would imagine the head would be.
So, and that's similar to kind of thinking about that ABR where we measure that electrical response from the brain. So I'm guessing there are certain locations that they
Yeah.
put it, but honestly, to be perfectly honest, I'm not exactly sure. That is a great question, and
Mhm.
I will ask our ENT if we have.
So that would be my guess.
Yes,
Yeah.
we can find out that information. Yes,
Yeah.
Dr. Olson.
Yeah.
Okay. So,
Just stick a little light.
yeah, the little switch.
Little light switch.
It's a kitchen
It's
for
the
us
circuit,
now.
you just push the button back in, the toaster pops, yeah. Okay, so auditory rehabilitation, so when we think about folks that don't have any hearing or learning auditory skills, that would be kind of our pediatric population, usually we call that habilitation. And then rehabilitation, folks that already have auditory skills, and we're kind of working on that. This is a very tough thing for audiologists because one would probably think that as an audiologist working with a cochlear implant patient, we would be the one to provide those services. But unfortunately, we don't get reimbursement. And so as you know, in the grand scheme of things as a provider and when you're at work and what things you can do and what things you can't do, it's very frustrating because a lot of times, I don't know about you guys, but I can have a stack of exercise videos, but am I gonna do those? I'm not the type of person that will. If I had a gym, you know, or a membership, I probably would go because I had something scheduled, I would go, I would do it. That's how it is with rehabilitation. We can give them a stack of workbooks, we can give them websites, and things like that, but it's truly finding your self-motivation to really learn to work with your cochlear implant. So it's a little bit challenging sometimes for the personality types to really get behind and start doing this.
Well, I can see, like you said, if they have a good support team and family help and encouragement, that would be a huge piece of it.
Absolutely. One patient, I said to her husband, I go, what I want you to do is literally, do you get the newspaper? And he's like, yes. I'm like, okay, I want you to read a sentence to your wife, and I want her to repeat it back to you. And so we're gonna build on these skills. So initially she can be looking at you and reading your lips, and you're gonna say, you know, the Bellingham Herald something, and so she can first do visual. Then we're gonna start doing where you cover up your mouth, and I want her to repeat back sentences to you, and I want you to say the words, and you know, so it's just this thing, and it's as simple as that. Reading the newspaper in the morning, take 10 minutes to do it every single day, or something, you know, just anything to work on that implant. So those are the types of things that you know, it's hard because you really want them to do these things, but I know life is busy, and so it's like, gotta have that motivation. Okay, so changing gears. Has anyone seen one of these wine bottles?
Yes.
I was like, why? It's so hard to get to your wine. I'm like, I do not like on a Friday. I would be like, I'm gonna break this thing. Yes. So it's like a puzzle. You have to stick the thing through, and there's these balls and this whole thing to be able to get that lid off.
Oh, that's cool.
I was like, my brain doesn't think that way.
Yeah.
Pulley system almost.
Yeah. So, yeah, I was like, I'm not into that. So anyways, okay.
You need the screw job.
Yes. So, it's true. Right, yeah, I just want that. Yeah. I don't even want to find the corkscrew. Okay. So, communication strategies, so factors that influence understanding conversation. So, this is kind of, I'm trying to keep track of time, but just thinking about this. So the speaker, how are they contributing to communication? So thinking about, are you mumbling? Are you chewing gum? Do you have your back to the person? Things like that. Factors that the speaker, if they're talking. Yes. Rate of speech. Yes. Also thinking about environment. So are you at home? Are the lights, is it dim? Are you out at a noisy restaurant? Are there, you know, side tables, things going on? Maybe it's a peak time at a restaurant. That's really going to impact your communication and conversation. The listener. When I get home from work, I have like 5 things I need to do immediately. First, feed my cat, because she is like meowing insanely. Second, I need to, you know, put my bag down, everything, well, that's probably first. Then feed my cat, then I'm gonna change, then I'm gonna go to the bathroom, then I'm gonna, you know, all those things that you're in that mode. I just got off work. So if someone's trying to talk to you, it's really hard at that time. So it's like thinking about, as the listener, just being like, you know what, honey, I need 5 minutes. And then I'll come back, I'd love to talk to you about that. So it's kind of that communication and setting up something that's gonna be, where it's gonna be successful, rather than kind of this halfway thing, and then it's like, what are you talking about? I didn't agree to go out to dinner with so-and-so. It's like, you know, these things where it's like, when did we talk about that?
Right.
And it's like, oh yeah, you caught me in that 5. Can't do it. Yes. Okay. So these are kind of just strategies, addressing your partner or communication partner by name, just saying, Katie, remember that question that I asked you earlier? Getting someone's attention rather than just going, oh, I wonder what happened to that question. Who am I talking to? I don't know. So it's kind of like getting someone's attention, dining with smaller groups, thinking about time of day with restaurants, maybe going a little bit earlier rather than those peak times. Prepared for noise. Noise is so difficult when we're trying to communicate, and being patient, and then improving one's communication can lead to a better quality of life for the person you're with. So whether you are the person with hearing loss or your friend, family member, spouse has the hearing loss. Okay, quickly I'll just run through. So 3 communication styles that we typically see. So this is also kind of my segue into, for you folks when you're working with people, as far as these communication strategies, making eye contact, coming to the person, not standing around the hall yelling, you know, when did so-and-so's order come in, or things like that. It's going to someone, getting their attention, talking to them. And it's sometimes we just want to get things done and we just want to quickly go, I need a chart note or I need this. And it's just, being an effective communicator, even with coworkers, and then also giving time and being patient with the people you're working with. So, passive communicators, oftentimes we see this a lot with folks with hearing loss because it's easier to withdraw, kind of become isolated, and not have to put in all the effort to watch every word and listen and be so focused on the communication. It's exhausting. So we'll see that folks will, or they will bluff. Yeah, and then that's what? And then it's like, oh, I have this one patient who's an amazing bluffer. He needs cochlear implants very badly, but he is not at a point in life where he's ready to make that step. And so I've just tried to counsel with him quite a bit. And one day he came in and he's just, and I'm talking to him, and all of a sudden I go, do you know what I'm talking about? And he's like, can you write it down? And I went, oh my gosh, I just talked to you for 5 minutes and you had no clue, because he's such a good bluffer that I just thought he's following right along. So, and the other interesting thing, the next communication style would be aggressive communicators. So those who attack the conversation and control it, because they do all the talking, they know what they're talking about, and so then they essentially will control the communication. So this patient that I was talking about, he is passive in life and going out and doing things like that. He's withdrawn and become very isolated, but when he comes to my office, can't get him to stop talking. The whole time he's controlling that conversation.
So he doesn't have to listen.
Exactly, because it's so much effort to have to listen to hear what I'm saying. So it's hard to see that, because it's like, this can't be a good quality of life. This can't be easy. So
Interesting.
yeah. And then assertive communicators often are not afraid to disclose their hearing loss. So in some situations, it's just better to kind of get it out there. I have some patients that are very assertive, and they advocate for themselves, and they'll have a pin or something. There's a hearing loss group, and so they'll say, I am hard of hearing. Look at me when you're talking to me, things like that. That just kind of has a little. So if you're one that could advocate for yourself like that, it's really great, because then you get your needs met as far as communicating. What does this all mean? Okay. So it's really, with these patients, we all work with these people. And so this is a short list of people that I basically am referring and getting referrals from on a daily basis. So I have a funny story about a physician assistant. At our work, we have one, his name is Chris. And he's like 6'2" or something, just like this extremely tall guy, and he's like an athlete, and he's like vegan or something. He's just like this really cool guy, and he's a physician assistant. And so I'm like, one day I'm doing a cleaning, and I get my patient in, and I look in his ears, and I'm like, oh, but I didn't do that. I was like, keep it together, because I saw in his ear little, what I thought were eggs. I was like, what? I'm going, oh no. And there's this little pile of these little white eggs, and I'm like, oh my gosh. So I take off the speculative, throw it away, get a new one, go to the other side. So I'm like, I'm not spreading those eggs from one side to the next. And I'm like, oh my gosh, infection control. I'm like about ready to put some gloves on. So I'm looking in there, and I'm like, oh my gosh, he has eggs in both of his ears. And I'm just like, what do I do? I'm like, it's Friday, Chris is here. So I like go running down the hall, and I'm like, Chris, I have a situation. I have a patient that has little eggs in his ears, both of them. And Chris is like, oh, okay. And he's very like cool, calm, and collected. And I'm like, what do we do? I'm like freaking out. And so he's like, okay, just put him in room 6. I'm like, okay. So I go and get the guy. I'm like, I'm just gonna have someone look in your ears. No big deal, nothing, it's all good, just follow me. So I bring him in there. And so I hear them kind of chuckling and talking, and then Chris comes out, and he's like, did you notice his tan? And I was like, what do you mean? It was sand in his ears, but it looked like all these little eggs. And I was like, oh my gosh. I was so embarrassed. And Chris is just like, don't worry about it. Because I'm like a new audiologist freaking out, going down my chain of command of what do I do. It was sand. So the patient, it was just like this funny joke, you know, it was like, there was eggs in my ears, but it looked, I was like panicked, so, I mean, you have to go to your team, your crew, your people, you know who your people are, it's like, help! So, yeah. Okay, so this is really wordy, but, yeah, just some facts for you. So nearly 50 million people have hearing loss. So it's like 20% of Americans have hearing loss. A lot of people.
Is it more male than female? Especially at an older age?
No.
So it can be both, but historically, men have more jobs where they're exposed to noise.
Yeah.
Occupational noise exposure increases hearing loss, and so that's why I see quite a few more male patients than female because of work history over time. So yes, that's a great question. Yes, they're very supportive. Yes. Yes.
It's funny you mention that. It reminded me, we do a lot of physical exams for commercial drivers.
Yep.
And
CDLs and all that.
we do a whisper test, okay, which is required by
Yes.
the DOT. However, if they are unable to pass the whisper test, we have to use the audio equipment. But the thing that's really interesting about these drivers is when you see the results graphically, their hearing is always, always on the left side worse than on the right side. And you tell them that, and they don't understand why, and say, well, when you drive, what is your window open or closed? And it's because a lot of these drivers are always driving with the windows open.
Yep.
And they constantly getting that wind noise and traffic noise and stuff,
Yeah.
and that ear is getting bombarded with that
Yeah.
stuff.
Yes, and we also see that with firearms. So I'm not really up on shooting, but it's the
Whatever
side
opposite
you're on.
ear where
Yeah.
it's this kickback where your
Yeah.
other ear is kind of down. So
Yeah.
we see some of these asymmetries in hearing. Yes, just like that. So yes. Okay. So 1 out of 3 people age 65 have hearing loss, and then when we go up to 70, 5 years older, it's 2 out of 3. So start thinking about the numbers, and it's pretty rapid that our population has a lot of folks with hearing loss. 60% of people with hearing loss are in the workforce. People are working longer. We are